Where are the groups of patients we should be referring for MRI imaging of their joint?
So right, there are obvious candidates. Okay? The obvious candidates are the patients who are completely asymptomatic and have got a car crash in their TMJs. And those patients are the really important ones, because I think those ones, the Orthodontic Society says you should check that the jaw joints are normal before you do orthodontics. And if it's not normal, you should proceed with caution. What I find in a lot of the reporting I do is that the radiologist looks at one single cut in the middle. And if the disc's sitting in the middle and it's sitting in a nice position, 12 o'clock position, and it looks like a bow tie on one single cut, the disc's in position as far as they're concerned. The worst thing that can happen when you order an MRI of a temporomandibular joint is it's going to be normal, which is a good thing, okay? Because then you don't have to worry about the temporomandibular joint anymore.
Protrusive, yet another kind of controversial episode. MRI imaging for the TMJs. I have had absolute authorities on TMD, such as MACSAC surgeons and those write the guidelines, who say MRI, meh, maybe someday if it may have a role. And the vast majority of patients probably don't need an MRI. And then I introduce you Dr. Kevin Lotzof, a radiologist, therefore, yes, some bias, but he strongly believes that we should be imaging the TMJs, like a lot more. Like, it is massively under-imaged and under-diagnosed in terms of the joint condition. So who's right and who's wrong? Well, this is what the podcast is all about. It's to allow us to listen to the different experts, the best out there at the moment, and you get to decide which path to follow. And I say this quite a lot on the podcast, guys, right? There are so many different ways to do anything in dentistry. Like, you bring 3 orthodontists in a room and you get them to do a treatment plan, and they will be wildly different. It's even more wildly contrasting in the TMD world. And even a single tooth with an MOD amalgam, you'll have 10 different ways of managing it from 8 different dentists, because 2 of those dentists are just stuck and they couldn't even make up their mind. And I guess the lack of rigid protocols I used to see as a frustration and a negative point about our career. But the moment I saw it as a beautiful thing, then actually, you know what? Our fulfillment and enjoyment, it significantly improves. Because guys, if you know that there is no strict right or wrong way, and that you are allowed to have an opinion, and that it is indeed the practice of dentistry, then suddenly the pressure is lifted from us. It heightens the role of finding your own path and having mentors, and actually just picking protocols and picking philosophies and being flexible enough and open-minded enough to change when you feel new evidence of new ideas emerge that fit with your values and are there to serve your patient. Hello, Protrusive, I'm Jaz Glati, and welcome back to your favorite dental podcast. If you are watching or listening to this on the app, the Protrusive Guidance app, you're going to get the full fat version of this episode. If you're listening on public versions like Spotify or YouTube, you're going to get a decent whack, but to protect our guest from being barraged by the members of the public, and also I want you guys to have his phone number. He's a radiologist who says that, look, give my phone number out, because he's not great with emails, but he's happy for you to call him when you have a patient who needs an MRI, for example, which I think is amazing, but obviously we don't want to give that out in the public. There's also some strong opinions, because like I said, right, different views, and Kevin's views are very strong, and I actually respect them a lot. And some of the stuff that his philosophy on treating TMD at the end, wow, that's killer. So if there's one reason to listen all the way to the end, you should listen to that. Now, to protect dentists and our profession and Kevin, some of the slightly more controversial stuff, the stronger opinions, I've saved them for the Protrusive Guidance version. So there's a free version and a paid version on Protrusive Guidance. Both of those will have the full fat version. Obviously, the free version will have the ads, etc. You don't get the transcript, you don't get the PDF notes, you don't get the premium notes, you don't get the CPD, etc. But you still can access the full fat version by going to protrusive.app. You can download the app on iOS or Android, but by making the account on www.protrusive.app first, you then get access to the free trials that we have and our best prices should you wish to upgrade. Now, if you are joining us on the app, we are manually approving everyone. No ifs, no buts. You have to be a dental professional to join our network. It's how we keep it a safe space. It's how we've made it the nicest and geekiest community of dentists in the world. Now, if you're nice and geeky and a dental professional and you have been waiting a while, it's probably because we didn't get enough evidence that you are a dental professional, and we've probably emailed you and sitting somewhere in your junk. If in doubt, please message us on Instagram at Protrusive Dental, and we'll find out how to expedite your entry once you can prove that you're a dental professional. professional. Now, a bit more about this episode. Like I said, controversial, strong opinions, which I welcome. But the kind of themes that we cover is, when is it appropriate to consider an MRI for your TMD patient? What's actually involved in an MRI of a TMJ? Can you actually use any MRI machine, or is there anything special about the center that you choose? Is it important who is actually reporting on this MRI? And let me just tell you now, it's a big fat yes. It's super important. And of course, what to actually tell your patient, what should they expect? All of that and so much more is covered. Dr. Kevin Lotzof is very straight talking. You'll absolutely love him. And of course, every PDP episode, I'll give you a Protrusive Dental Pearl. Today's pearl is from our community member, Dr. Rebecca Little. I'm really appreciating how some of you are helping out with the Protrusive Pearls. You know I get really stuck when I come to this part because we've done so many episodes now. I'm kind of running out of pearls. So I love being able to share yours. So Rebecca DM'd me on Protrusive Guidance. She's a very valued member of our community. And her pearl is, find the cancer today. Right? If you come with that mentality that when you're doing your examination or checkup, call it what you want, the mindset we should have is, let me try to find the cancer today. She said it's what goes through her head as she's doing a soft tissue examination or an extraoral examination. She's found a lot of weird and odd conditions, including good few cancers and also basal cell carcinomas on the head and face. You see, her dad was a GP and gave her his dermatology textbook. It's like a photo book, and that was really useful to her. And what a wonderful thing to look beyond the teeth, right? Oral cancer is one of the growing cancers in the world. And so I love this philosophy of try to find the cancer today. Thank you, Rebecca, for donating that pearl. And guys, please, if you have any pearls, DM me on Protrusive Guidance. I would love to share them with everyone else. And you are contributing to dentistry and you're helping me out in a stressful time. Anyway, enjoy this episode. Remember, the full fat version is on Protrusive Guidance. Check us out on protrusive.app. I'll catch you in the outro. Dr. Kevin Lotzof, so nice to finally put a face to the radiology report that I often see from you, the best reports in the business that I've seen, I have to say. I initially learned about you through Patrick Grossman, and I've learned so much from you. You've really benefited so many of my patients, and I feel this MRI for TMJs is it's become very niche, but I know what you believe in. It should not be as niche as it is. It has a huge role to play, okay? And before I get you to introduce yourself, I'm just setting the scene here because I've had guests on the show. I don't know if you've heard their episodes, right? I've had guests like Patrick Grossman, a huge believer in the power of MRI and imaging, whereas I have had maxillofacial surgeons, I've had those who write the guidelines say that, meh, MRI, maybe if someday, if this, that, and the other. So there's a huge, just like in the world of TMD, huge opinions, but today is all about you and your very valid opinion, Kevin. So please introduce yourself and tell us about your journey into venturing into radiology and how you've become known for TMJ imaging.
Right. So basically, I've been a consultant radiologist for 27 years. I did a little bit of MRI of the TMJs when I was a trainee radiologist, and then there was a surgeon by the name of Nasser, who used to work at Barnet Hospital, who used to do the surgery for the Patrick's group. And they were not particularly happy with the TMJ reporting that they had at the time. And Nasser said to me, would I look at the TMJ reports? And I said, absolutely. And I went to a meeting with Patrick, and that's the rest is history. So since 1998, I've been reporting TMJs. I have to say, I find it very rewarding. I think it's an incredibly interesting joint. And I think it is the problem with the TMJs, it falls between medicine and dentistry. And a lot of people just ignore it. And they feel that it's just not an important joint at all. And I think it potentially is one of the most important joints ever. So that's where I come from. Obviously, started with not many cases, and it's become a tsunami. I really am scanning a lot of patients. It's actually still a small portion of my practice, but nevertheless, it is, in terms of I only do private practice now, so I don't do any NHS work anymore. And I would say in terms of my private practice volume, it's probably about maybe 20%, maybe even less of my work.
That's actually huge, Kevin, isn't it? Because if you compare to your radiologist colleagues, they probably get a couple a year.
Well, no, absolutely. Listen, I do scan a lot of TMJs. I mean, I can do sometimes 60 patients a month. And that's a lot of patients. It does go up and down, but it's definitely increasing. And I do think it is completely under-imaged. And there are lots of reasons for that. And, you're talking earlier about the maxillofacial surgeons and do you need it or do you not need it? I don't even think they care whether there's a diagnosis or not sometimes. I get a patient, I got a referral the other day from a maxillofacial surgeon saying he wants a CT of the TMJs because he wants to do an arthroscopy and he needs to know the width of the bone between the joint and the skull base. So basically, he doesn't want to go into the brain when he does arthroscopy. But he doesn't know yet that the disc's out. So I'm thinking, well, why do an arthroscopy if you don't even know what the diagnosis is? And that's the kind of stuff that you're dealing with all the time in terms of the maxillofacial surgeons. And then there are people who I think should absolutely be imaging the joint who are not imaging the joint at all because they've been told that the joint's not important.
Orthodontists, right? That's what you're referring to?
Orthodontists, mainly. Prosthodontists seem to be moving faster than orthodontists, but even they would not really image all their patients. And I would say that if you're a dentist and you're sending a patient to an orthodontist, you maybe want to actually know that the patient should have orthodontics before you send them to the orthodontist. And maybe you should be saying, well, is the orthodontist I'm sending to this patient to aware of TMD, what it can do and how you should be treating these patients? I think that is a very reasonable question to ask.
There's very specific orthodontists that I use for my TMD patients because they've shown me that they have an interest and an understanding, and they really put that in part of their diagnosis and the foundation, because the foundation of the entire occlusion is, of course, the joints. I remember about maybe 18 months ago now, I remember referring you a patient. Before I started at ortho, I wanted to see what was going on in the joint, and it was a beautiful, healthy joint in the end, which is fine, but it gave me reassurance because some of the clinical presenting features that I saw were highly suspicious of exactly. And so I felt much safer continuing in that case. And then I remember you messaging me saying this is what we need more of, because a lot of the joints that you'll get even in seemingly healthy patients or mild symptoms, when you take the image, you're the one to tell us, is a completely different story.
Yeah, I mean, listen, by the same token I'm starting to see patients who are completely asymptomatic and have got a car crash in their TMJs. And those patients are the real important ones because I think those ones, the Orthodontic Society says you should check that the jaw joints are normal before you do the scan. And before you do orthodontics, and if it's not normal, you should proceed with caution. I mean, that's the best they say. And I would say that you can't tell whether these joints are normal just with a clinical examination. And I would say that without an MRI, you can't say whether it's normal or not. And if it's completely abnormal, whatever they look like clinically, you should proceed with caution, or you should certainly change the way you're doing your orthodontics. And I guess a lot of these patients are young. They're like 12, 13, 14. Those are the kind of patients where you could potentially salvage their temporomandibular joints if you do the right orthodontics at that time. You do the wrong orthodontics, you're stuck. So basically, I guess that is where I think we can really improve our.
I think the problem is, perceived problem, Kevin, right? Perceived problem in the UK is access. And I do think it's a real problem because whenever someone asks me that, Jazz, who do I use? Well, I'm like, I know, or I use Orient Imaging with you in London, but I know there are MRI centers across the UK, but I feel as though some of these centers may not have the correct coils or the correct equipment or the correct settings. I'm just guessing here. You know the state of the MRI centers in the UK. How many decent MRI centers with TMJs are there in the UK?
Okay, so in terms of the actual equipment, most scanners, most standard 1.5 or 3 Tesla scanners are sufficient to do TMJs. You don't need TMJ coils anymore. They used to need them, but they don't. The technique, though, is not well done anywhere other than a very few centers in this country, as far as I'm concerned. Some do them. I mean, obviously, I can't really comment on places where I don't work. And there occasionally I do get some really good scans to reread. But the key, I think, with the TMJ scanning is the planes that you obtain, the coronal images, and the field of view that you're using for the scan, and the position you get your closed mouth imaging in terms of getting your teeth clenched together, making sure the mouth's completely closed. In the coronals, it's an oblique image, and that varies for every patient. Not so much in the closed mouth position, but in the open mouth position, it definitely does vary, because it depends on where the condyle moves to, as to whether you get the right plane. And I've just seen a second opinion TMJ this morning where the coronals are completely in the wrong plane. As it works out, and they haven't done them in the open mouth image either. So basically, the planes, you can't tell whether the discs are medial or lateral. And that is a very important thing. And I don't think many radiologists even look for a medial or lateral displaced disc. They essentially, what I find in a lot of the reporting I do is that the radiologist looks at one single cut in the middle. And if the disc's sitting in the middle, and it's sitting in a nice position, 12 o'clock position, and it looks like a bow tie on one single cut, the disc's in position as far as they're concerned. But ultimately, that disc moves. So it can rotate, it can slip side to side, and you can have really severe TMD with a disc that looks completely normal on one cut. And I think that's what the coronal imaging is so important for, because it just gives you, especially the patient doesn't come with TMD symptoms. They come with, they can't hear. They feel like they're deaf. They feel like they got tinnitus. They feel like they've got vertigo, but they really don't. There's no objective science for all of that. But that's what a medial disc does. So I think the quality of imaging is poor in this country on the whole. The quality of reporting is even worse. And that's because no one looks at TMJs when they are training. I used to see trainees, and I used to show them this, and none of them had ever done it. And none of them are really that interested in it, because I think it's a bit of a Cinderella topic. They're not going to see a lot of patients, and they just don't bother with it.
That's been entirely my experience, where I've had MRIs that patients come with that haven't been taken with yourself, and then I look at it, and at the beginning, I thought, who am I to comment whether this report is good or not? I felt like, I should not be double guessing a radiologist. But then I just like, something's not right. And I send them to you, and I get a completely turnaround. And then you comment that, okay, the imaging is just about good enough. I mean, there are some issues here, kind of thing. And that just highlights the inadequacies in some centers. So this is a real issue. Again, go back to that access issue. Before we talk more about, okay, where are the different centers in the UK at least, but this is useful knowledge for everyone listening around the world. Dentists, we don't know much about this. So if we are referring a patient for an MRI, I think it's really useful for us to know, just a patient's perspective, what they're going to be expected to do, so we can tell our patients what to expect when they go. So can you give us like a couple minute summary of what the patient, the kind of images we need, or the kind of mouth open, mouth closed, and what we can tell our patients to expect?
Right. So the scan takes about 45 minutes. They come in, they go into a tube. It is a little bit claustrophobic because they end up with something called a head coil. So there's like a cage which goes over their head. Now you can see out the front of the cage, and there's like a little mirror which can help you see the tip of your toes. And most patients are absolutely fine with it. But if you are a little bit claustrophobic, I would say you should still try and have the scan. Maybe get a Valium from your GP before you go to help you calm down, and it's usually absolutely fine. So what happens is you lie down, they then acquire the closed mouth images, and there are 3 sets of images that you obtain. You obtain 2 sagittal closed images. One of those sagittal images is just to look at any fluid or things like that. The other one is an anatomical position, and then you're looking them at the images in the coronal oblique plane in the closed images, and then you get them to open their mouth. Now,
let's just talk about closed first, Kevin. So just talk about closed. So for most patients who are able to achieve a good interdigitation of their teeth and bite together, that's for them together. But a lot of our patients have a deranged occlusion following a change in their joint. So basically, it's close your teeth together as best as they fit at the current state.
And that's fine. And that's as long, and the radiographers know that. So, I mean, I can sometimes tell that they've got like a posterior open bite, because you can see that the condyles are sitting way at the back. And they've got a gap between their molars, and you know that they've got a posterior open bite. And there's really not much you can do about that. But you do the best you can in the closed mouth position, and then they get them to open their mouth as best they can. And what we tend to do with an open mouth scan is we give them a 50 milliliter syringe to bite on. And if they can open further than that, we put some swabs around the syringe to get their mouth further open. Now, some people have got, they've got too much pain. They can't open. They just can't open because their joint is locked. And then we just put smaller syringes in there. So that's the one thing we do with an open mouth image. And then so we do two sequences on the open. We just do a standard proton density and a coronal oblique. The coronal oblique's in a slightly different plane usually. And then we do a set of dynamic sequences, which we watch. We get the patient to open and close their mouth, and we scan them like real time.
Now, these are my favorite images.
Yeah. So they're your favorite images, but what you need to know is that it's only being done in the middle of the joint. So it's the middle cut. So a lot of stuff can be going on both sides of that cut, and you just don't appreciate it. So you've got to look at those images in conjunction with the normal open mouth images and the closed mouth images, because it could look completely normal on those images, and it's not. But I do agree with you. I think they're very useful in terms of function, and you can actually tell when the disc is recaptured. So whether it's an early recapture or a late recapture, those are the kind of things that I find are quite useful. And often, because they're not having to open their mouth for a long period of time, you get better functional idea of how far they can actually open, because they often do open further than on the static images. So those are the advantages of the dynamic images. So basically, they're all complementary to each other. I mean, most centers don't do dynamics. So I mean, if you're lucky, in most centers you'll get sagittals T1 and a T2 type weight to the image, and then you get like 1 or 2 in the open mouth image as well, and then you get 1 coronal in the closed. Often it's both joints at the same time in the coronal, and it's usually in the wrong plane in most centers.
So T1 and T2, this is something that also confuses dentists. Obviously, we ask for them. Can you just give us an idiot's guide to T1, T2?
Yeah. So you don't really need to ask any of that, because the radiographer should just do it. But an image is an anatomical image. It doesn't really tell you a huge amount of pathology sometimes. T2 just tells you about effusions and just if there's inflammation and things like that, edema in the bone. And that's what we use it for. And often, I use one sequence like that. It just, and I don't use it for the screening either.
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I wanted to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description. And thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode. Okay, and I think that this next question is going to be a very quick one because I think I know what we're going to say here. Some patients who are concerned about the claustrophobia element. Obviously, you gave us a tip for them to speak to their GPs to get some Valium. And then they Google and they say, oh, there are some open MRIs, okay? They are rubbish, right?
On the whole, they are rubbish. So most of them are, so basically you got to be looking for the field strength, which is the Tesla strength of the magnet. So 1.5 Tesla and up is okay. Now, there are some Tesla open MRIs. There was one in town. I'm not even sure if it exists anymore, but most of them are very low field strength images, machines. There are 2 problems with that. One is that the field of view is much bigger. 2, the time taken to acquire the images is much longer. So you could sit there for an hour and a half doing the standard TMJ with those sequences. If you're in pain, you move a lot. And an hour and a half is a long time to sit in one of those scanners, and the images just are rubbish. Now, the only time you really ever get good images on those machines is if you've got seriously very abnormal temporomandibular joints or seriously very normal temporomandibular joints. But anything in between is just a complete blur.
I thought you'd say that, and it's just good to know because people think and patients might ask us, so we just know generally want to avoid that because we get much better detail and quality from the standard MRI units. Now, let's talk about indications, right? Because let's face it, there are opposing views, and I think you made a good point about the kind of appetite of maxillofacial surgeons for imaging, why that should be different, why orthodontists should be doing it more. But in your clinical, with your clinical expertise and opinion, who is the ideal candidate for, so where are the groups of patients we should be referring for MRI imaging of their joint?
So, right, so there are obvious candidates. Okay? The obvious candidates are the patients with TMJ pain, clicking, locking, deviation. Those are basically, barn door TMD disease. I think even if you know they've got TMD disease, it's important to know what kind of TMD disease they've got. You can tell them if they're going to progress, how bad it is, et cetera, et cetera. I think it's useful prognostic. And then there are these, but I think even probably more important indications because these people sometimes think they are mad. So the middle ear issues, so deafness, query deafness, query tinnitus, query vertigo. These people, like, they see a million ENT surgeons, they get told there's nothing wrong with them, they got TMD. I think the biggest one that's underestimated is headaches. So I think young people with headaches, they just get told they got migraines, they get onto migraine medication. They all have an MRI brain, and the MRI brain's always normal. But if you really look at those MRI brains critically, and it depends on what sequences they've done on those brains. If they've done a sagittal sequence on the brains, you can actually look at the position of the discs. And I would say 50% of patients with headaches that have normal MRI brains and are labeled as migraine, they've got TMD. Actually see the discs are out. And it's really relevant in young patients, women in particular. They get a lot of headaches, they're anxious, A-type personalities. They've all got TMD. And then if you report, because I do a lot of just neuro brain reporting and not TMD related. and I mention the TMJs on the joints, I get letters back from neurologists saying, we don't want to go down that wormhole with TMD. Please don't even mention it. And I'm thinking, well, hang about. You've got a patient with an obvious disease and you're treating them for something else. And it's just crazy. And it is incredibly depressing to get letters like that. And I
Yeah,
get
no,
them
no.
all the bloody time.
I think you raise a very good point here. I think we need to listen to this. And so I think we've got a good indication. But what about in many dentist centers, we have cone beam CT machines. Can you
Yeah.
give any guidelines as to the value and the indications for those
In
instead
terms
of
of
an MRI?
TMD.
Yeah.
So I would say there is no substitute for an MRI. So you cone beam CT, if you can see TMD on a cone beam CT, you've missed it. You've missed the diagnosis. It's too late because you are now seeing bony changes and bony changes. So most people, when they report cone beam CTs, I don't think they really comment on the position of the condyle in the glenoid fossa. So yes, I guess if you've got an obviously posteriorly positioned condyle in the glenoid fossa, that will probably. I think with the cone beam CTs, if you can see TMD on a cone beam CT, you've missed it. It's too late. There's almost, you can do stuff about it, but the outcomes are not as good as if you make the diagnosis early. You can potentially see the condyles posteriorly positioned on the cone beam CT, but I don't know any radiologist that actually reports posterior position condyles. They're basically just looking at the teeth. And maybe if there's a bit of degenerative change, I don't even think they comment on whether the joint's narrow or not, to be perfectly honest with you. But there is no, in my opinion, there is no value in a cone beam CT to diagnose TMD. Now, maxillofacial surgeons like cone beam CTs because it tells them about how thin the roof of the glenoid fossa is. And when they want to go and do an arthroscopy, they don't want to go into the brain. So they sometimes ask for them. And there are some maxillofacial people who don't believe in the MRIs at all. And I don't know how they make the diagnosis to decide they want to go and do an arthroscopy. Because if I had a normal disc position and it was moving normally, there's no way I'd let a maxillofacial surgeon go anywhere near my temporomandibular joints. And of course you want to know that before you do any kind of surgery, no matter how good or bad it may be. I was going to say, just going back to indications for scanning, and I know we may get to this later, but I think it's quite useful to say that I would say to anybody, if you're going to be moving the teeth around, you should be getting a scan of the temporomandibular joints. And I guess even if the patient's completely asymptomatic, you should be doing that. You can get away with a one sequence scan in an asymptomatic patient in most of them. But if they're abnormal, then you should do the whole lot, even if they're asymptomatic.
So I think this is the screening option that you've made available, so that help us to not have to get the whole sequence, to try and save us money on the actual imaging for the patient as well, which I think is really clever, and it gives us that sense of security and confidence before we continue with moving the teeth around or doing major work. So tell us about the nuanced difference of a screening MRI for TMJ versus a full-blown one, and how we can refer our patients to get this.
So a screening TMJ scan is basically a 10-minute scan. It's one sequence. And I think, doing this for a long time, you can tell if someone's got significant TMD on one picture, one scan, okay? Looking from side to side, you can tell whether the disc's in the right position. You can almost always tell whether the disc's going to reduce, even though you're not even doing the dynamic side, just by looking at what the disc looks like, how the condyle looks. I mean, obviously you can be surprised, but you can tell pretty well with one sequence that they've got TMD or not. And I think that is a bloody useful thing to know. And I think it's a 10-minute scan. It's 200 quid, 250 quid, between 200 and 250 quid. I think it is way better than a cone beam CT, and it's probably the same bro. And I think that it's not, it's early days on this. I think I've scanned 5 patients, 5 asymptomatic patients, 4 of them completely abnormal. So I think the people who sending me these patients are not they're sending asymptomatic patients, but they have got some really weird bites and things like that they are suspecting, okay, they're asymptomatic, but But in my experience, they're going to maybe have TMD, and then we do the scan, and they do have. I have had
And what
one
do you
normal
do? So
patient.
at that screening one, so that's really useful to know. But in that screening scenario of those 4 patients that, oh, something's going on, then as part of the consent to the patient, if we find something, we're going to continue for the other 35 minutes of the scan, and then you're going to get a full one. Is that kind of conversation that happens?
No, we don't, because one, I'm not there real time. Wouldn't know that. They wouldn't know enough to make that decision. So I do say this patient should have a full scan. Having said that, the 4 of the 5, or the 1 didn't need it, the other 4 haven't had one yet. So orthodontists are worried, tell them that they shouldn't have orthodontics, and they're going to lose the patient. And the patients, because this is like a new thing, patients are saying, well, all my friends have had orthodontics and no one's had to have an MRI scan. Why am I having one? And I think that there is an education thing here that needs to happen for it to become an accepted bit of the treatment. But I do, and a couple of them, the dentists, I sent the report back to the dentist. Well, what am I going to do about this? And so then, but it's quite useful because on this I've got this TMJ group, and they put those they put the diagnosis on the group, and then people discuss it. And I think the right people in that kind of a setting, the patients will end up going to the right the practitioners. And I think that's quite a nice thing. And I see that it doesn't happen a lot yet, but it is definitely happening. And people are interested, and people are talking about it. And I think that it'll grow as we get more of these things. And I do think that ultimately, if I get 100 patients that are asymptomatic, and a lot of them are very abnormal, I think that's quite a compelling thing to then put down on paper and say, hey, look, these are abnormal patients. They've got terrible TMD. You're going to go and do orthodontics on these patients, and they're going to be in trouble. And I think we've got to those are the kind of things that I think are quite useful, and I think maybe will improve the outcome of TMD, because at the moment, and that TMD there's so many people who do so many different things for TMD. You've got to understand that if that's happening in medicine, no one really knows how to treat these patients. Because, if you've got a gallbladder and you've got cholecystitis, they take the gallbladder out and boom, bang, you're done. That is the accepted treatment. If you've got a hernia, someone fixes it. If you've got TMD, oh my God, you could have 5,000 different kinds of treatment.
It's the Wild West.
And no one really knows who's right. And I think the reason for that is that when I see these patients, a lot of them, it's very hard to actually make these patients better. And that's why we got to get them early. And the only way to get them early is to scan them before they have anything done to them.
I think that's a great point. And in our sort of some of the occlusal teachings that we do, Kevin, we say that, joint assessment. Now, how I got into TMD was complete by accident myself. I was restoring teeth, and I knew that it all starts by a joint examination, joint history. We want to make sure that we have what we call a green light joint that we can continue. And that's what led me to where I am now, where I'm doing on Mondays. I like a lot of TMD. I do only Mondays, Kevin, because I don't want to give up being a general dentist. I love my job.
And they might drive you mad.
Exactly. And I do, you know how the therapist, if you're a psychological therapist, right, you're supposed to legally, right, have your own therapist. And I felt as though I need my own therapist because, these are really, and I feel really bad for them, really emotionally driven consultations. They're really sorry situations. And, I feel really bad for them. And it does take your toll on you emotionally. I think the service that you offer and do is wonderful. Again, the access issue is there. So I can't talk about any other service in the UK, but at least I want to know, for those who are fortunate enough to have patients that can come to some of the centers that you're at, which are the centers where are Kevin approved, i.e. they'll do the imaging properly and then you'll do the reporting?
Right. So my favorite center is Orion. They do the most. Orion in Wimpole Street. But there are other centers. So in London, Orion, Spire Bushy, BMI, Circle Hendon, Circle Cavell, and Kings Oak. Those are like the 4 places where I work, and I do reasonable amounts, and the radiographers are pretty switched on. And if they don't get it right, I can tell them, hey guys, you messed it up, and they go and they do it again, and it's good. And I've also started doing them in Banbury at Foskett Hospital. So I do. Those are the places that I see patients and I do them. Very occasionally, they can be done in Lincoln. I report for Circle Lincoln, and some of the radiographers in Lincoln used to work in Hendon, so they know how the scan works, and I'm happy for them to do it. So I do work in Circle Health Group, and they are the biggest. They are the big private health group in the country, and I guess if people want to send patients to Circle hospitals and say they want me to report it, it could potentially be arranged, but the radiographers would need training. So I haven't really set that up yet, but I do. I report for 6 or 7 different Circle hospitals, and they know who I am, and it just gets done, and they get put on my work list, and it happens. But as I say, places where I'm really reporting at the moment are mainly around London, Banbury, and then occasionally Lincoln.
So what about those in Scotland? I get a message saying, hey, my patient's in Glasgow, they need an MRI, or my patient's in Manchester, wherever.
There are Circle hospitals.
What advice we give? Okay.
There are Circle hospitals in Scotland, and there are in Manchester. I don't have a relationship with them at the moment, but I guess if it's really something that wants to happen, I could probably make that happen.
Okay, that's good to know. So I think you said you're happy. You prefer phone conversations with dentists rather than email and stuff. So for those who are in the Protrusive Guidance app, your phone number for Kevin will be made available. If you're serious about incorporating imaging and joint diagnostics into your care that you provide your patients, then I think Kevin's a great person to speak to, and he may help you with the local service to try and get the right type of imaging so that you get a better quality diagnosis, better quality report, and Kevin's reports are the best. I sent him some filth reports before, and he's managed to get me a completely different diagnosis and a good quality report, even with some images that are suboptimal. So I look forward to sharing Kevin's details. I'll put all those sites that you mentioned, but also at least people have a few more options now. Kevin, any last words for colleagues listening today?
I think the thing about ordering MRI scans is, especially as a general dentist, you may find that some centers don't accept general dental referrals. I don't know why that is, but it's becoming harder to send images to send patients for requests. So I would say if that is the case, contact me. I can arrange, get around that. That's not a problem because I can okay those requests. The other thing to say is don't be scared. It's like, ooh, I've never ordered an MRI scan before. I might look like an idiot. Well, the worst thing that can happen when you order an MRI of a temporomandibular joint is it's going to be normal, which is a good thing. Okay, because then you don't have to worry about the temporomandibular joint anymore. And if it's abnormal, well, hey, you've made a good diagnosis. And I have to tell you that, I get patients from orthodontists, prosthodontists, maxillofacial surgeons, and they all get it wrong. Okay? No matter how good you think you are at examining the temporomandibular joint, you aren't that good because it's not a reflection of whether you're a good or bad clinician. It's just a hard thing to do. It's like trying to diagnose a cancer of the pancreas by putting your hand on the tummy. You can't do it. And people have terrible TMJ, and it sounds normal because the discs don't reduce, but they move all the way to the front. But hey, you've got terrible TMD and you've got like a closed lock, even though the discs, you seem to be moving normally. And people say, well, the right side of the patient's got the problem. You look at the jaw and the left side is 50 times worse. It's just been there for a long time. And the jaw, which is such a tolerant joint, it lasts with no pain for a long time. And until you move it and move it and move it around, and eventually it just gives up the ghost and the other side gets the pain. So I think those are the kind of things. Don't be scared. Just refer. You'll learn stuff that you've never knew existed.
100%. 100%. That's a great way to say it. And just learning itself and being able to think better. TMD is a thinker's game, right? And, let's talk about this because yes, you have the imaging, but with the 50 million ways that seem to exist to manage these patients, sometimes you're like, okay, well, now I have the imaging, but I still don't know how to treat this patient. Well, exactly.
Well, I guess you develop your own philosophy on that. I have my philosophy on TMD, and it's crazy that I have patients emailing me about what they should do about their TMD, and I don't even treat patients. I have a philosophy, and my philosophy is ultimately If you've got TMD and you don't have pain, that's a good thing, and you shouldn't try too hard to change anything else. You should just accept what you have and move forward. And then the other thing I would say to that is you should check that it's not progressing. So you should scan it again in, say, a year and make sure that there's no progressive disease, because TMD does progress. It does go from a reducing to a non-reducing disc, et cetera, et cetera. And so I would check that. And if it's not reducing, and you've got a splint, an anterior splint, and your pain's well controlled, I think that's a good thing. Now, listen, you're going to get guys on this group like Patrick will say, no, you have to go and, get the whole thing right and the occlusion right. And I respect that. But, would I want to go through all of that? I mean, it's a big deal, right? To go and have your discs put back and you with a terabyte and the splint all day long and all night long for 6 months or a year, whatever it is. That's a big commitment to make. Patients are prepared to make that commitment.
Mm-hmm.
I don't know.
That's
I
very
don't think.
fair.
Yeah. So that's what I tell. That's what patients. But I mean, I see so many car crashes. I see patients who've had mandibular advancement surgery because they've got posterior position condyles, so everything's sitting back. So they've now brought the mandible forward, but the condyles are still sitting back there. And these people are in intractable pain. And what do you do about those patients? The only thing you can do is redo the surgery and put the condyles back and bring the whole thing. Put the jaw back, bring the condyles forward. But then the jaw joints are so, really how much pain relief can you give them? I mean, some of these people get lucky. They get like that pseudo disc formation and fibrosis and their pain goes away. But it is a minefield. And the more you do, the harder it is to change.
Well said. I love that summary. I'm gonna keep that very much. Kevin, that was fantastic. I love how much passion you speak with, and it's great to hear that from you. Kevin, thank you so much for your time. I know you're a super busy guy, but this was amazing. I really appreciate your expertise and experience being shared here, and your real talk. You're very good at real talk. So thanks so much for that.
Pleasure. Thanks for having me.
Okay, there we have it, guys. Thank you so much for listening all the way to the end. If you're on Protrusive Guidance, scroll down below and you can answer the quiz to get your CPD or CE certificate. We are a PACE-approved education provider. Now, a bit of housekeeping and rules of engagement. If you are in the UK, for example, and you want to use Kevin for his TMJ imaging services, if you think your patient is suitable for a TMJ screening, it's actually a service that's in its early days, it's in its infancy. So, for example, if you were to refer a patient for a TMJ screening, the receptionist who picks up this query, they might not know what you're talking about. And if that's the case, you need to reach out to Kevin to help him train the receptionist, for example, so you get the right quote. So for example, a TMJ screening is about 200 or 250 pounds, whereas a full-blown TMJ MRI of all the things that we discussed in this episode, one of those is about 500 to 700 pounds. And if you want to use the screening service, yes, it's less money for your patient, and that's good, and it includes the report. But the most important thing is having options. So you said if you have a Circle healthcare center around you, then you could potentially benefit from TMJ MRI. Kevin may just have to reach out to them to help train them a bit so that he can get the best image quality possible, and then he can report your TMJ MRIs. I'm just here to help you guys in your journey. So if you're on Protrusive Guidance, scroll below. I'll have Kevin's phone number. You can text him, you can call him. He's a really sound guy, and he's happy to help you and thus help our patients. That's what it's ultimately all about. I want to thank Team Protrusive as always for doing a wonderful job with our episodes. They're getting slicker and slicker, and we're still having a lot of fun. We're enjoying serving dentists, and we're loving the comments that you give and the questions that you ask in the comments. So please do comment any episode ideas as always, and don't forget to hit that subscribe button. We'll catch you same time, same place next week. Bye for now.